Good afternoon, everyone. First of all, I would like to express my sincere thanks to our respected principal for initiation this organized CBL session. And I extend my warm welcome to all the participants, faculty members, and students. Last week, we successfully conducted the CBL session organized by the sports department. And now the neuro department is beginning the CBL session. And today is the case of a hemiplegic stroke with reflex seizure. And the presenter Priyanka will now begin the session.
Good afternoon to everyone. Case-based learning session, a case of left CVA with reflex seizure. Case scenario, subjective assessment. The patient name is Anjalam, age 40, referred by neuro department. Chief complaints is the patient's complaints of difficulty in lifting his left upper and lower limb since 10 months and unable to hold object in his left hand. And the patient complains of difficulty in doing his daily activities like dressing, combing, bathing, etc. Present history, the patient was normal 10 months back. After she developed an episode of fever, cold and numbness over the left upper and lower limb, followed by which the patient developed weakness, loss of sensation in left upper and lower limb. Then the patient got admitted in Sengalpatti GH for 3 months and came here for further physiotherapy management. The past history of the patient is the patient at age 12, the patient had a history of head injury followed by a fall into a water tank. Then after she experienced an episode of generalized tonic and clonic seizure, and the present drug history is tablet oxcarbazepine 150 mg and the tablet clobazam 5 mg. Seizure history, onset is 12 years of age, and the type is tonic-clonic seizure, and the next is aura phase, which occurs right before the seizure. So in that the patient present with headache, blurring vision. Next phase is ectal phase. So ectal phase means it is an actual period of seizure in that the patient will present with tonic contraction of limbs followed by clonic jerking movement of all 4 limbs. And the final phase is post-ectal phase. Post-ectal phase means it is an immediate phase, immediately after the seizure ends. That phase is post-ectal phase. In that, the patient will present with confusion, lethargy, retrograde amnesia, lasting for 3 to 4 minutes. And frequencies, initially it was recurrent, currently well controlled with medication and repeated exercise. Causes, chronic and intermittent episode since childhood. And the triggering factors for this patient is first is proprioceptive factor, which is active or passive movements, such as if the patient is initiating any example shoulder movement, shoulder flexion or something, the patient will present with seizure. So it is the first triggering factor. And the next is fever or cold. Third factor is emotional stress. Fourth is irregular medication. And the final is sudden bright light or flashing light. On observation, built mesomorphic gait, stiff knee gait. Deformity is in left fingers are extended. Mode of ambulation is independent ambulation. Muscle tone is spasticity. Attitude of limb is extensor synergy. Posture is in the shoulder, protraction, adduction, and interrotation. Elbow is extension. Wrist and fingers extension. Higher mental function. First is orientation. The patient is able to orient the place, person, time, and the attention is intact. And the memory is when the patient is completely normal, his short-term and intermediate and long-term memory is completely intact. After a seizure, if the patient present with each seizure, then she will go to retrograde amnesia for 2 to 3 minutes. Then after the patient will be completely normal. And the final is cognitive assessment. For cognitive assessment, Monreal cognitive assessment, so which scores 26 out of 30. Sensory assessment, first is dermatome level, area, right and left. So sensation is completely normal in left side, which grades 2, which is completely normal. And the sensation is left side is completely absent, so which grades 0. Motor assessment, in motor assessment, first is muscle tone. According to modified Ashworth scale in upper limb, which is left upper limb, shoulder, wrist, fingers, grade 1, which is slight increase in tone and the catch or release at end range of motion. And muscle tone in left lower limb, Hip, knee, ankle, grade 3, which means considerable increase in muscle tone and the passive movement is completely difficult. And the muscle power using manual muscle testing in elbow, grades 3, which is full range of motion against gravity, the patient is able to perform. And next is reflex, deep tendon reflex or exaggerated, which is biceps, knee jerk, everything is exaggerated. And the superficial reflex is plantar extension, which means positive Babinski reflex. Range of motion in left upper limb, which is passive range of motion. Shoulder flexion is 80 degree, extension is 5 degree, abduction is 20 degree. Elbow flexion is 0 to 100 degree, wrist flexion is 0 to 70 degree. And the passive range of motion in left lower limb, hip flexion is 50 degree, extension 5 degree, abduction is 20 degree. Knee flexion is 0 to 60 degree, ankle dorsiflexion is 0 to 5 degree, and plantar flexion is 10 degree. And the normal pathophysiology of motor system. So initially the primary, these four are the primary factors for the motor system. First is primary motor cortex, which origins from upper motor neurons, so which controls the voluntary movements and send the signals via corticospinal tract to lower motor neuron and spinal cord. So which is responsible for fine motor control, especially in distal muscles like fingers and hands. And the second one is corticospinal tract. So in corticospinal tract, it is lateral and anterior are there. First in lateral, it crosses at medulla, control the distal limb movements in hands and fingers. Next is anterior corticospinal tract, which controls the axial and proximal muscles. And the next is basal ganglia, which modulates movement initiation and suppression of unwanted movements, and it facilitates smooth voluntary motion. Final one is cerebellum, which promotes the coordinated, precise movement. It interrogates with sensory input for balance and motor refinement. And the pathophysiology after an injury, after a head injury, first is upper motor neuron damage, likely in primary motor cortex and corticospinal tract, which lead to weakness of left upper limb. And the spasticity and hypertonia occurs due to the loss of inhibitory signals from upper motor neuron to spinal reflex. Second one is corticospinal tract involvement. Corticospinal tract involvement, fine motor control is heavily dependent on lateral corticospinal tract fibers. If any damage, a person feels difficulty in doing the precision movements like buttoning, folding utensils. And next is neuroplasticity and secondary changes. After an injury, a muscle contraction and joint stiffness can develop due to the chronic spasticity. So altered cortical representation may contribute to persistent weakness and coordination defect. Last is balance issue. It could be due to weakness in proximal muscle, impaired proprioception, or cerebellar involvement. Movement-induced seizure. So it is a subtype of a reflex seizure, which is characterized by the onset of seizure in response to specific external stimuli or internal action. In case of movement-induced seizure, the trigger is typically a voluntary or involuntary movement. These seizures are often focal in onset, meaning they begin in a specific area of the brain and present with various manifestations. First one is dystonic posture, that is involuntary muscle contraction leading to abnormal posture. Tonic movement, rhythmic jerking of muscle. Tonic seizure, muscle stiffness or rigidity. So potential mechanism or association of the movement-induced seizure is, first thing is cortical hyperexcitability. So any damage in the part of area which is responsible for motor control will lead to the increase in neuronal excitability. So making them more susceptible to seizure activity during movement. The second factor is proprioceptive input. Movements that involve changes in body posture or muscle tension can provide a sensory input that may trigger seizure in some individuals. Underlying neurological conditions such as any cerebral palsy, traumatic brain injury, epileptic encephalopathies can can cause reflex seizure. Investigation: CT brain, subtle hypodense noted in right basal ganglia region. MRI brain, mild asymmetric bilateral hippocampal atrophy noted more in right side of mesial temporal lobe sclerosis. So mesial temporal lobe sclerosis means which is a neuronal loss and gliosis in mesial. Mesial means internal structure of a temporal region, mainly the hippocampal, amygdala, hippocampal gyrus. And this region are mainly responsible for memory, emotional, seizure control. And the mesial temporal lobe sclerosis is the most common pathological cause of temporal lobe sclerosis. Problem identification. First, according to ICF model, first is body function and structure impairment in this increased tone in left upper and lower limb, sensory loss over the left side of the body, and difficulty in doing fine motor skills, impaired gait pattern. Next is activity limitation. So the patient feels difficulty in lifting or holding object in left upper limb, difficulty in daily activities like dressing, combing hairs, and others, and performing and difficulty in performing fine motor skills like buttoning, writing, or pegboard tasks, and slowness and incoordination in bimanual tasks, reduced balance and mobility. Participation restrictions, reduced independence in personal self-care activities, difficulty in participating in household tasks and community activities, decreased confidence in performing work or social roles due to hand dysfunction. Clinical reasoning pathway, flowchart, first assessment. In assessment, tone according to modified Ashworth scale, grade 3. Range of motion in shoulder flexion, initially it was 10 degree, elbow flexion is 30 degree, wrist flexion is 5 degree, and balance according to Berg balance scale, 20 out of 56, and the functional independent measure 2 out of 7. Next problem list, increase the tone, reduce the range of motion, impact the gait, impact the aerial. And the goals are to reduce the tone, improve ROM, and improve balance. Intervention given is first is passive range of motion and immediate technique for spasticity, task-specific training for fine motor skills. And next is expected outcome in balance is 29 out of 56, and functional independence is 3 out of 7. Treatment goal setting. First is short-term goals, which is 2 to 4 weeks. First, in that, to improve the muscle strength from 2 to 3, and improve balance and coordination, enhance cognitive alertness and recall, prevent contraction and complication. The long-term goal is from 6 to 12 weeks. First is to achieve muscle power more than 4, and independent aerial, improve memory and attention. Next is to reduce seizure frequency and better community reintegration. Intervention plan according to the phases. It has 3 phases. First is acute phase, next is subacute phase, and final is chronic phase. And the acute phase is from 0 to 2 weeks. In the goal in the first phase is to maintain the joint range of motion, to facilitate muscle activation, and postural control, to ensure patients' safety, especially in seizure prone. And the last is to prevent complications such as contraction or pressure. So in the phase 1, the intervention first intervention is positioning, proper limb support, alternative side lying and supine lying. Next is shoulder movement in abduction and external rotation. Passive and passive range of motion, gentle passive range of motion for all major limbs 2 or 3 times a day, especially in shoulder, elbow, wrist, and ankle. Next, tone mimicry technique for spasticity. First is slow rhythmic rotation, prolonged stretching, and to maintain muscle length to reduce spasticity. Sensory stimulations, tactile and proprioceptive input to affected limb. Precautions, avoid overstimulation may trigger seizure. Monitor vitals and observe for post-ictal fatigue. And the next is phase 2, subacute phase, which starts from 2 weeks to 2 to 8 weeks. Goals is improve voluntary control, reduce abnormal tone and synergies, initiate functional movement training, begin balance and transfer activities. The intervention in the phase 2 is first is neurofacilitation technique. PNF, PNF technique in PNF technique, rhythmic initiation and hold relax for tone control. Next is NDT, Bobart approach, emphasize on trunk control and postural alignment. Active assisted and active exercise for bilateral activities for upper limbs. Example, rolling balls, towel slide. Next is using mirror therapy for visual feedback. Functional task practice, reaching, grasping, releasing or pegboard activities. Emphasize on task specific training to promote neuroplasticity, and the final one is balance and coordination. Sitting and standing balance retraining, use of balance board or foam surface, incorporate work balance scale activities. Final phase is a chronic phase, which starts from 8 weeks onwards, and the goal in the phase 3 is to maximize motor recovery and independence in ADL, strengthen the weaker muscles and improve endurance, enhance coordination, balance, gait, prevent recurrence of contraction and fall. The intervention in phase 3 is first is task-oriented and circuit training. ADL based activities, which is combing, reaching, dressing activities. Next is constraint induced movement therapy for affected limb, strengthening and endurance training, progressive resistor exercise for both limb, emphasize on antagonist muscle strength, gait and mobility training, weight shifting, step training, treadmill with partial body weight support, practice of stair climbing, directional changes, home exercise program, daily stretching and active limb use in self-care, family education for positioning and safety, precaution in seizure-prone patients, avoid bright lights or stress during the session, ensure proper rest between each exercise, allow always perform therapy in a safe environment with supervision. Outcome measures, day 1. In day 1, range of motion using goniometer, shoulder flexion is 10 degree, elbow flexion is 30 degree, wrist flexion is 5 degree. And in day before presentation, range of motion is in shoulder 0 to 80 degree, elbow flexion is 90 degree, wrist flexion is 20 degree. In Fugal Mayer assessment in day 1, upper limb is 10 scores 10. In day before presentation, the upper limb scores 15. In Berg balance scale, initially it was 20 out of 56, and the present Berg balance scale score is 29 out of 56. And the functional independent measure scores 2 out of 7, and the independent functional measure present is 3 out of 7. Time up and go test 15 seconds. Initially it was, now it was 9 seconds. 9 hole peg test initially to 38 seconds, now is 30 seconds. These are the evidence interrogation. Summary and take-home messages. 40 years old female with post-traumatic seizure disorder and left spastic hemiplegia following childhood head injury, and the mesial temporal lobe sclerosis, which lead to recurrent seizure, hippocampal neuronal loss, and memory deficit. The patient present with increased tone of MAS grade 3, reduced strength of 3, impaired gait and balance pattern. And the physiotherapy, our main physiotherapy is focused on tone reduction, neurofacilitation, that is PNF technique and NDT technique, and balance and gait retraining, and finally functional independence. Gradual improvement in mobility, coordination, and ADL performance observed with consistent therapy. These are the references.
It was a nice presentation, Priyanka. It was a nice initiation by the neuro team. We had a good presentation on the rare case scenario, I hope. I just want to have just one suggestion towards your presentation. I just want you to add the MRI report of the available. Means they would have taken it on different part of the life. No, what is the current age of the patient?
40, sir.
40, yes. So throughout our life, they would have taken some MRI at different episodes, right? So if possible, if you would have mapped it up, so we can understand, is there any progression in the damage happen in the brain, or it is sustaining the same? Do you have any information about that?
The 2 months before they took the MRI reports, sir, the same impression was there in that reports.
Okay, so there is no kind of progression or regression happened,
No, sir. No, sir.
right? Yes.
Yes.
Yeah, so you just make sure that you attach or present it somewhere in your presentation so that it is understood that the MRI taken on so and so date have the same presentation or same clinical findings, and MRI taken on the previous 2 months back also have the same presentation like that. If you would have mentioned it, it would be better. And then, out of my doubt only, I am asking, is there any guidelines for this treatment procedure?
No, sir. The exact guidelines was not there for this seizure with, CVA with seizure. Exact protocol was not there, sir. It is like CVA plus seizure. We have something interventions we have incorporated in this, in phase 1, phase 2, according to the patient we have incorporated, sir.
Okay, it was yes, it was a nice one. I hope you can make this as a case study, so that it will be the evidence will be also be available for others also. So just try to make this as a case study and publish in some journal. That's it from my side. Thank you for the presentation.
Thank you, sir.
Thanks everyone for your active participation. Thank you so much.